Good morning, dear students. Today we are going to talk about and revise about the topic of anti-epileptic drugs and epilepsy. We have already studied this topic in quite a detail during our regular classes with the epilepsy. And I'm going to talk about a scheme about the topic, and we are going to revise the topic in general. So first of all, in this presentation, we are going to talk about the various definitions and terminologies of anti-epileptic drugs, the historical overview, the classification of anti-epileptic drugs, etiologies and risk factors, then some classification of seizures. We'll see that where they differ amongst each other. And then we'll go on to discuss about the management of epilepsy, the treatment, the classification of drugs, their mechanisms, and then special cases. And lastly, we'll discuss about the modern advent of anti-epileptic drug therapy, as in vagal nerve stimulation and deep brain stimulations. So students, I am Dr. Sukhwant Singh, Associate Professor at SIRTS Pharmacy, the SAGE Group, and I am teaching you 4th semester pharmacology, and today's topic is anti-epileptic drugs. So the first point is epilepsy. Generally, epilepsy is defined as a disorder of the cerebral cortex characterized by recurrent seizures. Now, these seizures are periodic and or unpredictable. So basically, the cerebral cortex is having a disorder wherein it sends out certain signals which are classified as unpredictable or recurrent periodic seizures, which are accompanied by episodes of unconsciousness or amnesia also. So basically, in the cerebral cortex, there is some disorder that leads to sudden discharge of electrical impulses across the body, and as a result, various types of disorders are seen, and various types of epilepsies occur, and many of them have been defined. Globally, epilepsy is the third most common neurological disorder after the cerebrovascular and Alzheimer's disease. And epilepsy is not a single entity, but an assortment of different seizure types and syndromes originating from several mechanisms that have in common the sudden, excessive, and synchronous discharge of cerebral neurons. So, to explain it in very simple words, that our body's functions are basically transmitted across the body through various neurotransmitters, and these neurotransmitters are uh, released at the terminal boutons of various neurons, and as a result, the sensory and motor or mixed functions are carried out. Now, if some disorder happens and some disorder occurs, and as a result of that disorder, if these neurotransmitters are all of a sudden secreted in the terminals, in the synapse terminals, all of a sudden, then it will lead to a sudden discharge of electrical or sudden transmission of electrical impulse across the body. And due to this synchronous discharge of the cerebral neurons, excessive movement or jerks in the body can be seen, which can be motor, neural, or mixed in functions. And as a result, the patient's body undergoes a, a series of seizures, and the patient can either go unconsciousness. The patient can either go unconscious, or he can also face loss of memory during that period, or he may have no memory of whatsoever has occurred to him or her. So epilepsy is basically a group of variety of, it consists of variety of symptoms and syndromes, and usually it is defined into various subtypes of epilepsy depending on the type of symptoms that are present in an individual. Seizures are sudden, transitory, and uncontrolled episodes of brain dysfunction resulting from abnormal electrical discharge in the cerebral neuronal cells, associated with prolonged depolarization of cerebral neurons, result in motor, sensory, or behavioral change. So, just like I told in my previous, during the previous slide, I told that these seizures are sudden, transitory, and uncontrolled. episodes of brain dysfunction resulting from abnormal electrical discharge in cerebral neurons. And the site of origin of the abnormal neuron firing determines the symptoms that are produced. For example, if the motor cortex is involved, the patient may experience abnormal movements or generalized convulsions. So, if the motor cortex is involved, then of course abnormal movements and generalized convulsions will be observed. Seizures originating in the parietal or occipital lobe may include visual, auditory, and olfactory hallucinations because basically parietal and occipital lobes contain the centers of visually, auditory, and olfactory hallucinations. So usually it happens in such a function. Now seizures may either remain localized in case of focal epilepsy, or the seizures may also spread across the body in case of generalized epilepsies. Now, idiopathic, in most cases, epilepsy has no identifiable cause. I mean, you cannot exactly say that what the main idiopathic cause has been there. But of course, changes in physiological functions, factors such as alteration in blood gases, pH, which can be either because of the extreme acidosis or alkalosis, the imbalance of the electrolytes like hyponatremia or hypocalcemia, and blood glucose like hypoglycemia. This may be observed in patients who are having epilepsies, are having epilepsy. Then there are also certain factors which are related to the environmental factors such as sleep deprivation, or because of the alcohol intake or rapid withdrawal from the depressants and stress can also lead to etiology of seizures. And epilepsy can be due to an underlying hereditary reason due to a structural defect, whereas CNS infection occurs or a meningeal infections can be present or tumors may be there. Epilepsy can also be occurring because of metabolic defects or due to high fevers or even due to unknown causes also. So sometimes we can see transitory epilepsies because of high fever also. I have seen people who have shown a lot of epileptic seizures. Now, if we classify seizures as a whole, please see this slide very carefully and please understand this because this will constitute to the majority of the classification of seizures. So, seizures are basically classified into partial and generalized seizures. As you can see in this slide, that only a localized area of brain is shown to be dotted here, which shows that only a partial area of the brain is involved in the seizure. Whereas on the generalized part, we can see that whole of the brain is shown to be dotted, which shows that the whole brain is participating in the seizure activity. So when seizure activity starts only in one part of the brain, it is termed as the partial seizure. And when seizure activity is involved in the whole brain, then it is termed as generalized seizure. So first let us look at the partial seizure, that only if partial area of the brain or a part of the brain is participating in the seizure. In that case, it is classified into simple, complex, or with secondary generalizations. Simple will be where when during the seizure activity while the person is alert. Complex when seizure activity with change in the awareness of the surrounding, that the patient may be non-aware of, he can display blank looks when he's having a complex seizure. Or third, which is the secondary generalization, where seizure activity begins in one area and then spreads across the rest of the body or the rest of the brain. So this is about the partial epileptic seizures. Now, if I talk about the generalized seizure, it is the seizure where seizure activity is involving the whole brain. So if the whole brain is affected, definitely it will be having variety of syndromes, and almost all the functions of the body will be affected and hampered. And as a result, variety of classifications are seen in the generalized epileptic seizures. So the first classification of generalized seizures is absent seizures. The first category is absent seizures. Absent seizures, from its name, tells that seizures are usually not present. The person is having epilepsy, but his body will not be having jerky movements. So it is called as absent seizures. Here the person can be identified because he will be staring. He will be having a blank look and staring without any falling. This means that the person will be having a mask-like face and without any expressions. So it is called as absent seizures. The second category in this generalized seizures is myoclonic seizures. Myo means muscular, clonic means movements. So myoclonic seizures will be the ones in which the patient will be having jerking movements of the body. So this is myoclonic seizure. Then the next category of generalized seizures is tonic clonic seizures. Tonic means contraction, clonic means relaxation. So as a result, the body of the patient will be stiff. He may be falling from his gait and you can see a jerking movement in the body. So this is tonic clonic feature. Then there is tonic generalized feature, and the last one category is atonic. So the name tells tonic in that there will be heavy tonicity of the body, so body पूरी तरह अकड़ जाएगी, whereas atonic में body पूरी तरह relax हो जाएगी. So इस तरीके की classification we are having in epileptic seizures. So this is all about the classification of seizures. So seizures is classified into partial and generalized. The partial is further classified into simple, complex, and secondary generalizations, whereas generalized seizures are classified into absent seizures, myoclonic seizures, tonic-clonic seizures, tonic and atonic seizures respectively. Now let us talk about the partial seizures or the focal seizures. Its other name is focal seizures. So partial seizures are about 60% of the seizures that are present in the individuals are partial seizures or focal seizures. They start locally in a certain site and develop either into a simple partial seizure or complex partial seizure. The simple partial seizure may occur at any age without loss of consciousness, and it is characterized by Jacksonian motor epilepsy, which is having a convulsion in single group of muscle or a limb. यानी कोई एक हाथ या कोई एक पाँव या कोई एक मसल का सिस्टम ही convulsion में जाएगा. So this is type of simple partial motor epilepsy. The complex partial, which is having psychomotor, which involves psychomotor or temporal lobe, in this it is associated with loss of consciousness for about 30 seconds to 2 minutes. यानी complex partial seizure में patient को 30 seconds लेके 2 मिनट तक consciousness का भी loss हो जाएगा, वो patient बेहोश हो जाएगा. And there are disturbances of cognitive, affective and psychomotor movements and sensory hallucinations. So इस प्रकार की डिस्टर्बेंसेस, जब उसको कोग्निटिव डिस्टर्बेंसेस हो रहे हैं, अफेक्टिव डिस्टर्बेंसेस हो रहे हैं और साइकोमोटर डिस्टर्बेंसेस हो रहे हैं. इसके अलावा सेंसरी हेलुसिनेशंस भी पेशेंट को हो सकते हैं इन केस ऑफ कॉम्प्लेक्स पार्शियल सीजर्स. 80% ऑफ इंडिविजुअल्स एक्सपीरियंस देयर इनिशियल सीजर्स बिफोर 20 इयर्स ऑफ एज. यानी किसी पेशेंट को यदि होना होगा तो लगभग उसकी उम्र के 20 साल से पहले उसको लगभग ये सीजर्स हो जाते हैं. Now if we talk about generalized seizures, they begin locally and the spread of the seizure is rapid. It affects the whole brain. Both of the hemispheres are affected, may be convulsive or non-convulsive. That means the convulsions can be present or they may be absent in case of absent seizures. And the most important character is immediate loss of consciousness occurs in the patients with generalized seizures. It is divided into 5 categories, as I told. Tonic-clonic, or also called as grand mal epilepsy. Absent seizures, also called as petit mal epilepsy. Myoclonic seizures, febrile seizures, and status epilepticus. Please note that the questions that usually come in university level are asked through these names also. Explain about grand mal epilepsy, explain about petit mal epilepsy. So please do not confuse yourself. Grand mal epilepsy is tonic-clonic and petit mal epilepsy is absent seizures. So first of all, let us talk about the tonic-clonic. Patient falls in convulsions and may bite his tongue and may also lose the control of his bladder or bowel because of excessive tonicity and clonicity. In tonic seizures, some patients after dropping unconsciousness experience only the tonic or the clonic phase of seizures. Then there is an atonic seizure, also termed as akinetic seizure, which starts between the age of 2 to 5 years. The patient's legs simply give under him and drops. The patient is, if the patient is standing, he drops down. And then lastly, the absence seizures or the loss of consciousness without involving motor area, and it is most common in the children of the age of 4 to 12 years. Myoclonic are usually rare and they occur at any age. These are sudden, brief, shock-like contractions which may involve the entire body or be confined to the face, trunk, or extremities. It may reoccur for several minutes. Then febrile seizures, usually occurring in the young children from 3 months to 5 years, with illness accompanied by high fever, as I told you, consist of generalized tonic-clonic convulsions with short duration. And lastly, the status epilepticus, which is recurring seizures. Continuous series of rapid recurrent seizures occur, tonic-clonic without intervening return of uh, consciousness. It is a life-threatening emergency, and the patient may also die if not treated instantly. So these are certain first aids for seizures, what is to be done and what is not to be done. For example, the patient should be cushioned in their head, remove harmful objects nearby, aid in breathing by, um, placing the patient in recovery positions, etc. And give them anything need to drink when they until they are fully recovered. So these are certain do's and don'ts. Now, the management of epilepsy I've already talked in my previous classes, and I'm not much discussing that, but of course I'm going to discuss about anti-epileptic drugs. Anti-epileptic drugs are indicated when there is 2 or more seizures which are occurring in a short interval of time, and the drug of choice is based upon the classification of seizure, what type of seizure the patient is having, whether he's having generalized or whether he's having localized, or whether they are tonic-clonic or petit mal or grand mal. So first of all, the drug of choice will depend on the classification, on what the type of seizure is present. And secondly, the patient's age and health state is also a factor which determines what the drug is to be given. And lastly, data on efficacy, tolerability, safety, and pharmacokinetics is to be seen for an individual patient in order to determine the drug of choice which is to be given to the patient. So the treatment, when it starts, it should start low and go slow. This is the standard thumb rule when starting a patient's treatment for epilepsy. The prescription should always be started with single drug at a small dose, and all common side effects must be discussed with the patient, etc. And importance of compliance should be stressed on the patient कि दवा यदि नहीं ली तो उसके क्या नुकसान हो सकते हैं, that should be stressed. Now, if we talk about the historical overview, what are the drugs that have been used? Modern treatment of seizures started in the year 1850 with the introduction of bromides, which was based on the theory that epilepsy was caused due to excessive drives. Then in 1910, phenobarbital was the first drug that became the drug of choice for many years in the year 1910. A number of medications similar to phenobarbital were developed, including primidone that we have discussed in my previous class. And finally, in the year 1940, phenytoin, this is why. Phenytoin had become a major first-line anti-epileptic drugs AED in the treatment of partial and secondarily generalized seizures. In 1968, carbamazepine or CBZ was approved initially for the treatment of trigeminal neuralgia, and later in 1974, it was approved for partial seizures. And ethosuximide has been used since 1958, and valproate or sodium valproate was licensed in Europe in 1960 and in the United States in 1978, and is now widely available throughout the world. And it is one of the most important drug of choices that I have discussed in my previous theory class. So various classes before 1990, the drugs which were used are termed under the classical drugs. It includes phenytoin, phenobarbital, primidone, carbamazepine, ethosuximide, valproic acid, and benzodiazepines. These are all classical drugs which were introduced before 1990, and the newer drugs used after 1990 are Felbetol, Neurontoin, Topamax, Keppra. These are various drugs, and we have discussed about these. Lamotrigine we have discussed, topiramate we have discussed, Tigabine we have discussed, Tigabine we have already discussed. Okay. So anti-epileptic drugs, how do they act? Anti-epileptic drugs act by either blocking the initiation of electrical discharge from the focal area or prevent the spread of abnormal discharges to the adjacent brain area. यानी कि या तो ब्रेन से इलेक्ट्रिकल डिस्चार्ज को इनिशिएट होने से ही रोक देना, और या फिर ब्रेन से यदि डिस्चार्ज हुआ है और सिग्नल स्टार्ट हो गया है तो उस सिग्नल को पूरी बॉडी में स्प्रेड होने से रोकना। जो भी नॉर्मल इलेक्ट्रिकल डिस्चार्ज है ब्रेन के आसपास के इलाके में, उसको स्प्रेड होने से रोकना है ताकि पूरी बॉडी में सिग्नल, जो एक्सेसिव अनवांटेड सिग्नल है, वो न जाए। AEDs prevent depolarization by modification of ion conductance, that is direct membrane stabilization, inhibition of excitatory activity और stimulation of inhibitory activity, है ना। तो या तो excitatory एक्टिविटी को इनहिबिट करना है और इनहिबिटरी एक्टिविटी को स्टिमुलेट करना है। हमको पता है हमारी बॉडी में दो प्रकार के एक्टिविटीज हैं। पहला ग्लूटामिर्जिक है, जो कि एक एक्साइटेटरी सिग्नल है, हम चाहते हैं कि ये सिग्नल ब्लॉक हो जाए। और दूसरा गाबानर्जिक है, हमको पता है गाबानर्जिक एक इनहिबिटरी न्यूरोट्रांसमीटर है, तो यदि हम इसको स्टिमुलेट कर दें गाबानर्जिक को तो इनहिबिशन अपने आप हो जाएगा। तो ये दो तरीके हैं जिससे बहुत इजीली हम किया जा सकता है। और तीसरा है आयन कंडक्टेंस का मॉडिफिकेशन, ताकि मेम्ब्रेन स्टेबलाइजेशन को किया जा सके। So they how they do their work, they decrease axonal conduction by preventing sodium influx through fast sodium channels। यानी जो फास्ट सोडियम चैनल्स हैं उनको ये इनहिबिट करता है, एक्सोनल कंडक्शन को कम करके। एग्जांपल ऑफ दिस ड्रग्स आर कार्बामाज़ेपाइन, ऑक्सीकार्बामाज़ेपाइन, फेनाइटोइन, and they are also known to decrease the presynaptic calcium influx through type T channels in thalamic neurons। तो जो थैलेमिक न्यूरॉन्स हैं टाइप टी चैनल्स उसके अंदर प्रेजेंट होता है, जो कि कैल्शियम के इन्फ्लक्स को बढ़ाता है, ये उसको घटाते हैं ताकि कैल्शियम का इन्फ्लक्स ना हो पाए। इसके एग्जांपल्स हैं इथोसक्सिमाइड और वैल्प्रोइक एसिड। ये देख लीजिए आप कि 3 एंटी एपिलेप्टिक ड्रग्स हैं, इनको जब दिया गया कंट्रोल पेशेंट के मुकाबले तो किस प्रकार उन्होंने काम किया है। ये वाली स्लाइड मैंने लास्ट टाइम भी डिस्कस करी थी आप लोगों से। कंट्रोल ग्रुप में ये एपिलेप्टिक के सीजर्स हमको दिखाई दे रहे हैं। फेनाटोइन देते से ये पूरे एपिलेप्टिक सीजर्स गायब हो गए हैं, जबकि कार्बामाज़ेपाइन में धीरे धीरे घटा है और सिग्नल एकदम गायब हो गया है। और वैल्प्रोइक एसिड में भी तुरंत सिग्नल घटे और सीजर्स गायब हो गए। यहाँ इस को देखने समझ में आता है कि फेनाटोइन बहुत इफेक्टिवली इलेक्ट्रिकल डिस्चार्ज को ब्लॉक कर पाने में सक्षम है एज कंपेयर टू कार्बामाज़ेपाइन एंड सोडियम वैल्प्रोइट। कंट्रोल ग्रुप ये रहा जहाँ पे ये सारे इलेक्ट्रिकल सिग्नल्स हमको बराबर दिखाई दे रहे हैं। So they do their actions by increasing the inhibitory tone through felicitation of GABA-mediated hyperpolarization. The example of these drugs are barbiturates and benzodiazepines। ये GABA को बढ़ा देती हैं। GABA इनहिबिटरी न्यूरोट्रांसमीटर है और GABA यदि सीक्रेट होगा तो इनहिबिशन होता है। उसके बाद they also inhibit GABA metabolism, जैसे कि वैल्प्रोइक एसिड और विगाबैट्रिन है, ये गाबा के मेटाबॉलिज्म को रोक देते हैं, तो इनहिबिटरी इफेक्ट काफी लंबा रहेगा। और तीसरा है बाई एक्शन ऑन द रीअपटेक ऑफ गाबा, तो गाबा का रीअपटेक को भी रोक देते हैं ताकि गाबा उस इलाके में बना रहे और इनहिबिशन प्रोलॉन्ग होता रहे। दे आल्सो डिक्रीज द इफेक्ट्स ऑफ ग्लूटामिक एसिड। ग्लूटामिक एसिड एक एक्साइटेटरी न्यूरोट्रांसमीटर है, तो ये उसको अगर इनहिबिट करोगे आप तो ऑटोमेटिकली एक्साइटेटरी इफेक्ट कम हो जाएंगे। एग्जांपल ऑफ द ड्रग्स आर लेमोट्राइजीन, topiramate, etc. These block AMPA receptors, and felbamate and phenobarbital blocks the NMDA receptors। So last time we have discussed this slide where we talked about how the anti-epileptic drugs act, और ये सारा तरीका हमने लास्ट टाइम बहुत ज्यादा डिटेल में पढ़ा था। आप जैसे इसको देख लें, आपको समझ आया, सेल्फ एक्सप्लेनेटरी है काफी ये डायग्राम। सो अगर हम इसकी फार्माकोलॉजिकल क्लासिफिकेशन की बात करें तो आयन चैनल्स पे काम करने वाले ड्रग्स में आता है, सोडियम चैनल पे काम करने वाले ड्रग है फेनाइटोइन, कार्बामाज़ेपाइन, लेमोट्राइजीन, टोपिरामेट, वैल्प्रोइक एसिड ऐसे। और जनरलाइज्ड टोनिक-क्लोनिक पार्शियल सीजर्स में जिसमें कैल्शियम चैनल्स पे काम करने वाली ड्रग्स हैं इथोसक्सिमाइड, वैल्प्रोइक एसिड, जोनिसामाइड, एंड दीज आर फॉर एब्सेंट सीजर्स। एनहांस इनहिबिटरी एक्शन एग्जांपल इसके हैं आपके डायज़ेपाम, बेंजोडाइज़ेपीन के, बार्बिट्रेट्स, वैल्प्रोइक एसिड ऐसे। And most effective in myoclonic but also in tonic-clonic and partial seizures, and clonazepam for absent seizures. And these are the drug of choices for the treatment of variety of seizures, which I talked in my last class also. That in case of grand mal, the drug of grand mal epilepsy, that is tonic-clonic seizure, grand mal epilepsy it is called. The drug of choices are carbamazepine or valproic acid or phenytoin or phenobarbital. Alternatives, which are the newer ones, include topiramate, lamotrigine, gabapentin. Partial, simple or complex, the drug of choice is carbamazepine or phenytoin or valproic acid. Alternatives can be phenobarbital, lamotrigine, etc. And in petit mal epilepsy, which is the absent seizure epilepsy, the drug of choice is ethosuximide or valproate. In myoclonic atonic seizures, the drug of choice is valproate. In status epilepticus, the drug of choice is diazepam or phenytoin intravenous or valproate also. Now the pharmacokinetics, we have already talked that usually these drugs are very good, are having very good pharmacokinetic profile. They are having very good absorption, although most of them are sparingly soluble. They have got low plasma protein binding, except for phenytoin, benzodiazepines, valproate and tijabine. Conversion into their active metabolites also, that once they are metabolized, then again they are converted into active metabolites. They've got the phenytoin is having variety of adverse effects. I'm not going to talk about it more today, but of course we are going to talk about whenever you have doubt in this case. Just go through what teratogenicity it can show. You can see here that the upper palate of the patient of the fetus is not developed, and as a result, this type of syndromes are seen. The carbamazepine's pharmacokinetics, it is absorbed slowly, enters brain rapidly. Potent inducer of hepatic drug metabolism enzymes. Its own half-life reduces over 2 to 3 weeks. Increased metabolism of theophylline, warfarin, and various hormones. Complex drug interactions with other anticonvulsant agents is also seen. There are also associated adverse effects of carbamazepine, including stupor, coma, respiratory dizziness, drowsiness, vertigo, ataxia, etc. Sodium valproate inhibits the P450 system. Therefore, its adverse effects are seen in elevated liver enzymes, tremor, hair loss, changes in hair growth, increased appetite, weight gain, etc. Then we are also having gabapentin, which is a newer drug used as an adjunct in partial and generalized tonic-clonic seizures. It does not induce liver enzyme, and it is not bound to the plasma protein. And its drug-drug interactions are negligible, but it is a low potency drug. Then vigabatrin, it is a prescription drug for partial seizures, inhibits GABA transaminase. Its adverse effects can be depression, psychosis, and visual dysfunctions. Lamotrigine, last time we talked about, it is presently used as an add-on therapy with valproic acid, almost completely absorbed. T-half is around 24 hours. Low plasma protein binding blocks sodium channel and high voltage calcium channels, and thus it is effective with partial generalized myoclonic and absent seizures. And it is also approved for the use in bipolar disorders. Now, status epilepticus is a life-threatening status, and it requires emergency treatment, usually consisting of administration of a fast-acting medication such as benzodiazepine, followed by a slower-acting medication like phenytoin. And benzodiazepines are usually given intravenous so that instant action is seen in the patient. Of course, special case pregnancy where in pregnancy the seizures are fatal. If uterine contractions occur, the patient may undergo instant abortion. So therefore, significant problem is there in a patient who is pregnant as well as having epilepsy. So in that patient, monotherapy is usually better than drug combination. And newborns of mothers receiving phenobarbital and phenytoin may develop hyperprothromenia, hemorrhages prevented by vitamin E. Then these are newer therapies that have come up for seizure, but of course, since it is not part of our syllabus, so I'll not talk about it. But I'll just let you know that these are vagal nerve stimulation, VNS, which is a surgical implant of a small pulse generator with the battery and a lead wire for stimulus. Okay, so this is in the patient. where lead wires are wrapped around the patient's vagal nerve, and it acts like that. Then there's also treatment in deep brain stimulation or DBS, where pacemaker-like device is used to deliver targeted electrical stimulations to the anterior nucleus of the thalamus. So thank you very much. Thank you for your time. I'll be uploading this class through my WhatsApp and as well as in the Facebook. Kindly contact me whenever you want so that we may discuss about any doubts that you'll be having. The questions that usually come in RGPV are usually on the general classification of epilepsy, what are the various types of epilepsy that are occurring, and also on the treatment of epilepsy. But since epilepsy is having a variety of names, so usually the examiners tends to ask the variety of names of epilepsy. Like the question can be explain about grand mal epilepsy or explain about the petit mal epilepsy. So you need not confuse, but just keep in mind that what are the different names of epilepsy. Otherwise, the questions are quite simple, and sometimes simple questions are also asked, like classify anti-epileptic drugs, wherein you will have to classify the drugs on the basis of either their pharmacology or on the basis of their mode of actions. So now I'm Dr. Sukhwant Singh signing off on the anti-epileptic drugs. Hope to see you soon. Stay safe, stay inside. Goodbye. God bless you all.